So thank you for holding up the surgery for a bit. Anna apparently is going to be streaming this talk, so if we can just cut down some of that background noise from the equipment in the surgery and everyone just take a seat. Talk will be about 25 minutes or so. So this will be streamed out, and then we'll get back to your surgery. I'm going to give the next talk on ACL reconstructions, and this does not mean at the end of the talk we start our ACLs. As Dr. Ryu said today, we have all day long to get through the surgeries. Some of you advanced. We're pushing ahead with the lecture. Some of you a little bit more basic, and that's okay. We'll just stay here as long as we need to. At the end of the talk, we'll have another hour or two in the lab before lunch comes. So like all the speakers here, I have no personal financial disclosure. I kind of like this slide. For those of you who do ACL reconstructions, who understand Maslow's hierarchy of needs, we go down from physiological to safety to love to esteem. And then we get to self-actualization. But one more, for some surgeons here in the room, is the anterior cruciate ligament. It's probably not that important, but it could be. And so we're going to talk about it because we can argue the number, but several 100,000 people a year seem to be injuring their knees. And we know that women are doing it more than men, at least in the NCAAs, it appears. We know kids now are doing tons of sports, so they're ramping up. And whatever the middle-aged population is, my dad and his dad weren't doing the sports that we were doing, so everyone's a target for it. And we can credit many people for, including Dr. Fu, trying to figure out how this ACL works. And we're going to say that maybe it has two bundles. It probably has a lot more, but that's how we describe it. The anteromedial and the posterolateral. The blood supply is not great. It comes from the middle geniculate artery and it goes down the synovial tissue. And so we all know that when you pop your ACL, not a lot of good blood. The little blood there is gets washed off and things don't heal. But perhaps if we restore the blood flow, maybe we can do primary repairs. And so Dr. Martha Murray up in Boston and her husband, who has to be in my group, Dr. Braden Fleming, have been working on this biologic enhancement. And I'm not so sure that in another 5 to 10 years, we're not going to be teaching primary repairs again here at this course. And the other thing is kind of interesting. When you blow out your knee, you lose some proprioception. We all understand that. You get the quadriceps avoidance gait, but there's some new studies coming out that perhaps if you can stabilize the knee, maybe the blood supply is really not the problem. Maybe if we can just stabilize that joint, the body will try to turn itself on and repair that ligament tear. So new research says if you can hold the knee stable, a repair may occur. Who cares in this room? Because in a few years, maybe we're going to be teaching internal splints and braces for our reconstructions. So these may rapidly change in the next couple of years as research pushes us forward. Everybody understands the 6 degrees of freedom. It's amazing that we, for 20 years or so, were teaching how to stabilize the knee in a single plane when in fact everybody knew there is translations and rotations. And again, many of our research colleagues have told us that maybe the reasons for our failures is we're not stabilizing the knee in an appropriate way. So this ACL-PCL is a 4-bar linkage, and when it pops, the knee will not function normally until you get it back in an anatomic location. So, it won't work. So everyone in this room knows that when you see someone coming in and they got a swollen knee with an appropriate history, we're not going to call it a sprain. We're orthopedic surgeons. We're going to move forward, and we're going to make a diagnosis. If you go to Brown University, it is nuts because we actually, at least I do, ask you to touch patients. It's actually almost a lost art. Now, we have MRIs, but those of us in the room who are instructors who've been out in practice long enough have been burned so many times that we've gone back to try to learn how to do a physical exam. So I just suggest you want to start from the neutral point when you examine knees. Don't assume everyone's ACL is torn when a knee is sloppy. And it's an art. It's an art to learn how to examine your patients. But there's two things we want to do. We know this is a Lockman test. Sometimes it's just a bit of a soft endpoint. Sometimes it's significant excursion. And so we also talk about rotatory dysformity because we're going to talk about that later today, the posterolateral corner, and a pivot shift when your IT band helps you to push out. In my office, people don't like this. In the operating room, this is critical to understand the degree of their laxity. And KT1000s are really great. It's a cool instrument for study and research, but it's a single plane deformity you're measuring, and that's not really state-of-the-art anymore. This is where the younger surgeons pop in. They're going to get an x-ray looking for Sagan fractures, arthritis, physis status for the kids and the alignment. How about the posterior tibial slope? There's all sorts of things we're looking at now to see where these kids are going to go, but we all jump to the MRI. And I will just tell you, the dreaded hedge call is rampant in New England, maybe in your area too. You should look at all of your own films. You should know how to read MRIs. You can't trust, and I don't mean this in a negative way, but I don't think as a surgeon you should just trust the read on the MRI films themselves. Michael Feldman showed this slide this morning. I thought he stole it from me. He says when you do a diagnostic scope, you have to touch the patient. So he clearly stole that from Brown. Touch the patient in the knee. So those of you today, I watched you, you did some diagnostic scoping. I dare say some of you never touched the inside of the knee that you examined. You got right to the meniscus. You might want to touch your patients. So on the left is a normal looking ACL, beautiful vascular supply over the synovium. And on the right, you put a probe in, the ACL is gone. It's almost identical to what Dr. Feldman showed us this morning. So you might want to touch your patient. So let's get on to why I'm here this morning. ACL Graft Reconstruction. 20 years ago, at a different building, I stood at the podium and we said, here, we got a BTB and off we go. The list on the right, I just ran out of space. So I don't think today, for those of you who want to push ahead with ACL reconstructions, there's one or only one way of doing it. And that slide on the bottom left is part of the work by Dr. Murray and Dr. Fleming. We're probably going to be doing primary repairs again in a couple of years. So you just want to have the basic skills and understanding of where sort of the anatomy is so that we construct it with whatever skill set we have. And the other big thing was, well, West Coast, they do it this way, and East Coast, they do it that way, and what's the best way to do it? And I will suggest there is no best way of doing it unless you just did it correctly. And correctly done surgery usually works very well. So here are the options. Horrible graft, basic concepts are, there are advantages and disadvantages to all. So when I talk to my patients, I give them the advantages, I give them the disadvantages. I've done everything you can dream of, and you just do what works well in your hands. But I think you owe it to your patients to at least talk to them about the different types of graft choices that are available. So how bad does it get? I went to, the expert panel, those guys, the experts, they sit up there and mumble along. And one guy said, God almighty, I counted over 50 different ways out there of different exhibits to do ACL reconstructions. So it becomes mind-numbing on how to do this stuff. We're going to try to strip it down today, for those who push ahead, to the basic elements of how to get a reconstruction done. This is for Dr. Feldman, single bundle versus double bundle. We're going to say that the double bundle probably makes more sense anatomically, and in a lab it does great. We're not so sure clinically. It may not. We don't know yet. It's, again, a level up of technique. So for those of you who are interested, we can do those today. So when I see patients, I can tell you for all of you, the Academy wants you to make sure that you get the correct side and the consent. Sounds idiotic, but I think all of you now, with all the electronic systems, you cannot make that mistake anymore. And number two, touch the patient before you operate on their knee or shoulder, and get an instability exam and a motion exam. It will save you a lot of heartache at the end of your surgery if you miss something by not examining them. If you want to do the actual repair itself, my cherry picking is for the proximal tears that are just avulsed off, and I think I can get them back. And so these are actually a lot of fun with the new suture punches. You can put permanent suture, high-strength suture through there, and some sort of fixation device into the femur. You can pick around there to increase the blood supply through a microfracture technique. And actually, these athletes or patients will do very well. But in my hands, we're cherry-picking until I can get the biology of Dr. Fleming and Murray to wrap around this thing. So we're going to make tunnels today, because that's what surgeons do. And we all know that actually we have to get them in the right position or the patient won't do as well. So I'm old, and I started way back when, just as we got from open to arthroscopic surgery, a long time ago. And the crazy thing is, about 30 years ago, somebody suggested that we put the ACL back in its anatomic position. And so we did, with 2 incisions. And that's in the upper right. You can see a picture of what's called the rear entry guide. And we did that for a decade until someone came along and said, wowzer, we can do this transtibial endoscopic, and the cooler surgeons, those guys, the cooler surgeons are not putting that side incision on. My. So if you were an older surgeon doing a 2-incision technique, your patients left you for the younger guy or lady who did the single incision. And so it took off like there was no tomorrow. And I went to all those academy meetings that all the attendings did, and we had speaker after speaker telling you how great this was because, you know, that's what it was. The lab showed it. And it took some real guts to say, maybe we only fixed a single plane deformity and we didn't get to the rotatory deformity. So all of a sudden, somebody rolls in with this thing called anatomic repair. It's incredible. We went back to the future. And so I go to the academy and there's an instructional course lecture, Back to the Future. Now that's cheating because that guy took that from one of my talks. But the concept is we are not doing anything today in this lab that we didn't teach 30 years ago. We just got sidetracked. So we're going back to the anatomic. Old school, same patient. On your left, her right, it was on her first date. She met a man. They went skiing. First run down the mountain, blows her ACL out. She comes. I fix it, outside in. 25 years ago. She dumps him, she becomes a ski instructor. 25 years later, comes in, tears her left knee. I fix her. She's on her left knee, on the right on your view. And so there's old school, new school, almost looks identical. That right knee doesn't look like it's loaded with arthritis 25 years later in someone who's a professional skier. So I think if we can do really good surgery, we might expect pretty good results. One of my favorites for the young surgeons here is the residence ridge. I don't know why it's the residence ridge. The attending never let you do any of the surgery. It's really the attending ridge. And what that meant is we missed where the anatomic circle was. And so we all understand now the intercondylar ridge, the ACL is behind it. We understand sometimes there is a bifurcate ridge. There's a spread of the bundles of the ACL. And so Dr. Feldman, I think, uses X-ray in his surgery. A lot of surgeons do. However you can get to the point, you just have to find out where is the anatomic part. So the surgeons in here have to teach the young surgeons, and over time, JBJS, just last year, trends in femoral drill tunning. The tibial tunnel, the transtibial, maybe we'll talk about it later tonight, seems to be on the decline around the country. However, the low anteromedial portal and the lateral approach with the retro flip cutter type devices are becoming more and more popular. So that's something that we have to teach here today. And if you do these transtibial, which I did for years, I can tell you they're pretty hard. And you still go around the country, and there are many, many surgeons who believe this is still a great technique, but technically it's hard to get that ACL in the femur where you want it to go. There is some wizardry that you have to do, and there are compromises of the fixation. So I think there are easier ways to do it. Old school, antegrade, those devices are still around. Absolutely identical. New school, retro cutters, pulling back. You end up in the exact same place in the exact same way. If you do the low anteromedial portal, it's pretty good. It allows you that independent drilling. You just have to be careful because a couple of things. One, when your guides come through, you smash that condyle. So we do a little iatrogenesis, and good surgeons really don't like to do that, so you have to be very careful. You got to really flex the knee, which puts surgeons in an awkward position looking at anatomy they don't normally look at, and their pump shuts down, so the knee dries out. So this is a little bit more, again, technically demanding to do. And lastly, when I do these, I make sure my fellow's on the other side. He's got some skin in the game because you get awfully close to that peroneal nerve, and you can get some postoperative problems if that comes out. So another way to do it, we have a lot of vendors here today. Safer control, the guide wire, the tunnel exit, you can use angled reamers. So you can put it so it comes out exactly where you want, and you don't have to worry where it comes out. So what do I do in the operating room? I put it where the patient had it. I clean them out. I get down to where the old ACL plugged in, and however I get to that, I do them all different techniques. I want to get the tunnel where it is, and I want to look up the tunnel to make sure I really got a good tunnel. On the tibia, it's a little tiny bit more wiggle room. Unless you're doing endoscopic, you got to be pretty oblique. So for the tibial tunnel, we want it to come out, and there's some articles in arthroscopy and the other journals that you have to be pretty careful not to clip the horns of the meniscus. You can do that, the anterior horns. If you misfire, sometimes the lateral meniscus or even the medial meniscus will be cut out of there. So especially if you're doing double bundles, because you're chewing up a lot of territory. So I use the silly impingement guide when I do my tunnels. I want to make absolutely sure that my tibia is in a place that's not impinging the graft. I did this 30 years ago, and I'm still today. I want my graft to live. If you're doing the hamstring grafts, pretty easy to take out, and that's the first graft we'll take out today, I suggest, because you don't chew up the front of the knee. And so you want to make a small incision, but as we said, many of you have never done open surgery, so you're not sure where nerves are, et cetera. You want to know exactly where you are and what potential problems you'll get into. Now, it used to be you took both of the hamstrings out, but now we can maybe just take one. The concept is unchanged. You want to get as much length as you can, and you want to be careful of these fascial bands. It is amazing how easy it is to clip these tendons, and when I do hamstring repairs, this clearly, in my hands, is the longest part of the surgery. I do not want to come out with a compromised graft, so I waste a lot of time with my fingers up there making sure I get enough tendon all the way up, not to clip it and come out with a half a graft. So you can take one tendon out or you can take two, but you have to make sure the whole length of the tendon comes out, and that's something you have to practice. Obviously here today, you don't have the proximal pull, so it's going to be a little bit awkward in a cadaver. When you prep that hamstring, this is where we can cheat a little bit, like leaving a lot of crap on the tendon, and then you say, I got a 9 or 10 millimeter graft. You really don't. Hamstrings are a little bit smaller, and they then get even smaller. As one of my colleagues back at Brown, these hamstring grafts can get even a little thinner. So you have to be careful. At least in my world, I think size matters a little bit. So you want to make sure you get a big enough graft in there. And so some people will tell the families if it's too small, they're going to use an allograft, quad it up, triple it up, just get a backup plan to get enough tissue inside the joint. If you're going to do patella tendons, anterior incision, please save the paratenon. I only need 2 centimeter bone plugs. I don't think you want a big whack out of the patella, knock on my head. I've never had a patella break on me. And the old days, we would use osteotomes. People get arthritis. You can just very gently get that plug out and not bugger up your patella. The magic sauce for these is that how do you stop a graft tunnel mismatch? And that's why one reason many people hate using these grafts, because you can't get it to fit easy, where hamstrings, it's a slam dunk. They always fit beautifully. So there are these little techniques, N+5, N+7, talk to your instructors. How do they try to measure so that it's bone-to-bone perfect at the aperture and it's not sticking out of the bone? I think these are probably the coolest, the quad tendons, and I've done them. For some reason, there's not a lot of traction in America today for quad tendons, and I think it's growing. But here today, if you have time and you've done a lot of reconstructions, I would go after the quad tendon itself. And now we got the graft out, we've chosen how we want to do it, and now we got to fix it. Cortical suspension is a pretty good idea. We started with fixed cortical suspension, nice and thick, nice and strong. They closed the loop for us. There's no knot tying, no elongation, and that was, again, the standard. But there are these newer widgets out there that can adjust. And so they can be used in these shorter tunnels because we're getting anatomic reconstructions. The wiggle room is getting less and less and less. So there's less mucking around. There's less measuring for the surgeon. There's a whole lot more wiggle room. So this is something that's nice, and you can tighten it up after you're done. There was one concern that maybe they loosen over time. My sense is that other articles state that maybe that's not a true clinical factor or biomechanical factor. They seem to be pretty strong. But if you're going to use these, I suggest when you're doing your tunnel reaming, I photograph every single patient, every single button, we call it, or the donut, as the button goes through. I've had a few revisions where the endo button or whatever structure you have, the fixed button, cortical button, is halfway down the tunnel. What the surgeon did is never looked up here at the top. These are shorter tunnels, never photographed it. This is soft tissue through here. Maybe there's some bone over here. Felt pretty good. That patient went to recovery, and the cortical button fell right down. Failed in the recovery room. We all have had that experience. I think if you photograph a nice thick donut up here, you're pretty good. Finally, we're going to finish the surgery off. Tibial bone is much weaker, so we have to get some sort of fixation, and it runs parallel. So the graft's going to pull right out. So there's different fixation devices. You have to get comfortable with all of them. This is one such a device where it pushes up the middle and pushes the tendon in all 4 directions into bone. Seems to make, at least to me, some sort of common sense, and the literature shows actually fixes good. Just as popular, all inside cortical suspension. And so you can pull in both directions and adjust that graft to get as tight a graft as you can. When you're done with your surgery, I hope no matter ORIF to arthroscopy, I would get my x-rays in the operating room, and I would make sure that everything is looking pretty good, because here's one of those revisions I got. Someone got an x-ray and the endo button was halfway down the tunnel. Needless to say, that patient failed their surgery and had an unstable knee. So I want to get my x-rays always before that patient gets out of the OR to document that I put it in the right place and time. So as I said, what we're going to do is go back to the meniscal work. If it takes you all morning, that's good, because we have time. We're going to graduate this out. And the other thing we're going to do is that for the post-test, we all did meniscectomies last night. Somewhere this morning, either on the way to lunch or after our talk and question answer, we got all afternoon in the lab. We would like everyone who did a meniscectomy on the simulator yesterday just sneak out and take a post-test so we can analyze how you all did. So I think we're going to go for another hour and a half to 2 hours before we start lunch. So we'll turn on the monitors, turn on the machines, and we'll see you at lunch. Thank you.